Hello, my name is Chris Fry. Today we will be sharing a video tutorial on how to perform ultrasound-guided injections of the radiocarpal and tarsocrural joints in the dog. We have no conflicts of interest to disclose. Ultrasound-guided technique allows visualization of the joint space and confirmation of the needle path and location prior to injection. Benefits of using ultrasound guidance were discussed in the first video in this series. Preparation for approach to these joints is similar to those discussed in the first video in this series. Differences for these smaller joints include the length of the needle and the volume of injectate. Most canine carpi and tarsi require a 22 gauge needle of 1.5 inches in length for large or giant breeds and 1 inch for medium to small breeds. A 25 gauge 1 inch needle can be used for smaller to toy breeds. The amount of injectate will vary depending on the size of the dog and the joint to be injected, but given the smaller overall space of these joints, less injectate volume is used, typically ranging from 0.25 to 1 cc in a 30 kilogram dog, with the carpus less amenable to larger volumes. Triamcinolone acetonide is commonly dosed at 0.2 mg/kg and split across up to 2 target joints being injected and may be paired with hyaluronic acid. Anatomic landmarks are used to begin your ultrasound approach. Follow the radius distally by palpation and you will feel a soft divot on the dorsal surface of the radiocarpal joint that marks the primary center of motion during flexion and extension of the carpus. The accessory cephalic vein runs superficially over this area and should be avoided. It may be displaced with a finger or probe to keep it out of the path of the needle. For injection, the carpus should be held in flexion and the limb externally rotated to facilitate placement of the ultrasound transducer dorsally over the carpus. This allows you to obtain a long axis view of the radiocarpal joint space where you previously palpated the divot. Identify and inspect some of the more distal carpal joints by translating the probe distally and then returning proximally. This allows for broader inspection of the carpus, such as degenerative changes, synovitis, and effusion, as well as helps provide context for probe positioning when targeting the radiocarpal joint space. An ideal window will have a visible pocket of synovial fluid upon slowly flexing and extending the carpus, helping to determine the best angle for approach. Highly effused carpi may be accessed with a more superficial approach and the carpus in a more extended position. However, carpi with minimal to no effusion typically benefit from a more flexed position and a steeper needle trajectory. The needle is passed bevel up from the distal aspect of the transducer in alignment with the long axis of the probe and under the skin. Once the needle is first visualized by the probe, it may be redirected within the subcutaneous tissue before proceeding to ensure the correct trajectory toward the target of the radiocarpal joint. Once the tip of the needle is visualized within the joint space, synovial fluid may be aspirated for diagnostics or confirmation of placement and then followed by therapeutic injection. The transducer should remain in place during injection so that distension of the joint capsule and recesses may be visualized prior to removal of the needle. The tarsus should be held in extension and the limb externally rotated to facilitate placement of the ultrasound transducer cranially over the distal tibia. The probe should be moved distally over the dorsal aspect of the tarsus to obtain a short axis view of the tarsocrural joint space. Settle the probe once the distinct medial and lateral trochlear ridges of the talus are visualized. Blood vessels can be seen running over the flexor surface of the tarsus and should be avoided with needle placement. The ideal window is a pocket of synovial fluid found between these talar ridges. The ultrasound probe should be rocked back medially, thereby optimizing the approach to the valley between the talar ridges. The needle is passed bevel up from the lateral aspect of the transducer in alignment with the long axis of the probe and under the skin. Once the needle is first visualized by the probe, it may be